structure discussion basically. Very
Yes,
not
ma'am.
that good, not that good structure discussion, but okay, let's discuss that. Okay, started. Okay.
Right. Next, ma'am. Next. Next. Next.
No, that's it. I have questions for you. I will be asking.
Okay, madam.
You want to
Okay,
go to
start.
any of the page?
Uh, uh, Referral later. শব্দ করো না এখন। Okay. Okay, ma'am. Starting.
No, last
Hello.
45 second. Last 45 second, you can take your time to organize your thought process.
Okay, ma'am. Okay.
8 second.
Check.
Okay, done.
Yes. Hello, I'm Arifa, Patri candidate. I am one of the exam candidate. I have read the scenarios and ready for structured discussion.
Okay, so now you are going to see this case of genital prolapse. What information you wanted to know from this case?
Yes. Okay. So I'm discussing this patient with the is bar format. This discussion came for the genital prolapse. There were 67 years and had symptoms of the last 12 months and course. Regarding assessment, I will assess the patient, and before that, I will introduce myself. And assessment will be done by the taking a meticulous history, examination, and relevant investigations. Then regarding management, I will manage the patient under multidisciplinary team approach, and management will be depend upon the patient age, severity of the symptoms, staging of the prolapse, and her wishes. So, regarding history taking, I would like to inquire about the duration of the symptoms and severity of the symptoms, whether it is affecting her quality of life by asking some questionnaire screening tool, and whether she had any associated symptoms like pain, dragging sensation, whether any urinary symptoms like urgency, frequency, any history of recurrent urinary tract infection, any signs of other infection, and any stress urinary incontinence or urge incontinence. Apart from this, we will inquire about the any complaint within the bowel. And patient will be asked about whether she needs to be visited whether during defecation or urination, and whether it is reducible. Then I will inquire about the risk factors for the genital prolapse. Most importantly, obstetric history, like whether she has, how many children she have, and what is the mode of delivery, and during delivery, any history of prolonged labor, obstructed labor, on any difficult labor, what was the outcome, and what was the birth weight of the baby. And after every delivery, whether she was continuing pelvic floor muscle exercise or not, and I will review her previous all the delivery notes with her permission. Then also her medical history, like whether she has any cough, chronic constipation, bronchial asthma. Also, she was a smoker, and inquire about her BMI. and need to know her occupation, whether she is having heavy lifting or heavy exercise, because all these important to know her risk factors. If these risk factor present, that time it can affect the treatment outcome, and chance of recurrence will be more. Then I will inquire about her menopausal status, whether she has, since how long she is having menopause, whether any sign symptoms of menopause, and whether she is on any hormone replacement therapy. And I will ask about very sensitively after signposting about the sexual history, whether she is sexually active. If yes, what about the any dyspareunia or any vaginal dryness. Then I will inquire about any previous surgery, because it can affect the surgical outcome. And also inquire about any drug allergy, what she treatment taken so far, whether she taken any pelvic floor muscle exercise or any conservative management. Because if all the conservative management fail, that time we need to go for the definitive management, that is the surgical management. And also I would like to know about her mental status, as she is 67 years menopausal and having these distressing symptoms, and need to inquire about her support, and also whether she has any concern. And then I will examine her in the presence of a chaperone. Madam, should I move on?
Yeah, information
Oh,
gathering involves history,
yeah.
examination, and what investigation you will be arranging.
Yeah. So regarding examination, I will offer her examination in the presence of chaperone. And first of all, I will look for any genital atrophy, any vaginal discharge, any abnormal bleeding, and what is the condition of the skin. Then I will do per speculum examination to see whether any decubitus ulcer, or whether status of the cervix, and any discharge. And also I would like to ask her cough to elicit whether any stress urinary incontinence. If any stress urinary incontinence, that time we need to evaluate whether it is genuine stress incontinence or stress incontinence due to prolapse. Then I will do bimanual examination to see whether any adnexal pathology. But before that, I will also do parabdominal examination, whether any mass or any pain tenderness is there. After that, I need to do investigation. But genital prolapse is the clinical diagnosis. No investigation is needed for confirmation of the diagnosis. We will offer investigation just to see whether any associated complaint, or for the management part. So I will do urine analysis for my routine microscopy and sorry. Yeah. Okay. So then I will offer her urodynamic testing, as we may go for surgical management. So before that, we will need to confirm whether any stress incontinence, or whether any overactive bladder. And if there is any mass or any other abdominal pathology, we may need to do for CT or advanced stage, that is CT MRI. Okay.
Okay, so this is your information. How you are going to examine this patient?
Yeah. Okay, so during examination, I will most importantly, I will stage, and I will first of all I will confirm the type of prolapse, whether it is uterine, or whether it is associated cystocele or rectocele. And for staging of the prolapse, I will do pelvic organ prolapse quantification system. It is a standard international system. It is measured by 9 points. Hymen is the leading point, and any points above the hymen, that is negative point, and any points below the hymen, it is considered positive. And there are 2 points on the anterior vaginal wall, and 2 points on the posterior vaginal wall, that is AA and BA, and AP and BP. And C is cervix, and D is the posterior fornix. But if any history of previous vaginal hysterectomy, that time D will be absent, and all the points will be measured during the maximum Valsalva maneuver, except the total vaginal length. It will be measured after reducing the prolapse part. And all the measurement will be put on the grid, and then staging will be done. So there are 4 stages, stage 0 to 4. Stage 0 means no prolapse. Stage 1 means more than -1 but less than +1. Stage 2 more than +1 but less than total vaginal length -2. And stage 4 is complete procedentia, that means more than prolapse but more than total vaginal length -2. Yes.
Okay. Okay, now how you are going to manage this case?
Okay. So before managing, for further management of the patient, first of all, I will counsel the patient regarding her diagnosis. That is, what is genitalia? It is the descent of the pelvic organ prolapse to the vagina due to weakening of the pelvic floor muscles and supports of ligaments. And then I will counsel about what is the treatment options, and tell her that management options depend upon her age, staging and severity of the prolapse, and also her and considering her wish. So first of all, I will give her general management and option for lifestyle modification. If she has in high BMI, so need to reduce her weight, I will refer to the dietitian and exercise specialist group, and avoid smoking. And if any history of heavy weight lifting, that needs to avoid it. And any history of comorbidities like chronic cough, constipation, or bronchial asthma will refer to the physician for proper control of the this condition, because it can affect the outcome of the treatment. After that, we will tell the patient that treatment options like no treatment, non-surgical, and surgical. But as she has symptoms, so no treatment will be not suitable for her. And if she has not given any previous non-surgical management, then I will offer non-surgical management first. That is pelvic floor muscle exercise. Usually, it is suitable for stage 1 and stage 2 prolapse. It is very effective. I will refer her to the physiotherapist, and it will be done under the supervision. That is 8 contraction 3 times per day, and it needs to be continued for at least 16 weeks. Then follow-up will be done after 16 weeks. Most of the cases, 50 to 60% of cases, it will be improved if it is done properly. Uh, then along with this, we will counsel that another non-surgical option, that is the pessary. But pessary, it is usually pessary can be given in all stage, but usually suitable who do not wish to go for surgery, or who will not fit for surgery due to some comorbidities, like medical and surgical comorbidities. Then I will counsel that what is pessary. It is the silicone and plastic device inserted through the vagina. It can help to place the pelvic organ prolapse in normal position. It is outpatient procedure, no anesthesia needed. There are certain types of pessary. It will be dependent on whether she is sexually active or not. And after that, patient will be counseled that she needs to be followed up in the dedicated pessary clinic, first in the 6 weeks, then every 6 monthly. After 6 weeks follow-up, she will be inquired about whether any bleeding, any discharge, or any discomfort, and whether pessary is in place. And she needs to be counseled about how to clean and how to change the pessary. But there are some complications regarding pessary, like sometimes chance of pain, bleeding, infections, erosion, or ulceration can happen. And sometimes if it is neglected case, or patient not need any regular follow-up, that time removal, it is impacted within the vagina, and removal can be difficult. Then I will go for the surgical management. Regarding surgical management, there are options like vaginal hysterectomy with anterior or anterior or posterior pelvic floor repair if associated with the cystocele and rectocele. Other option is uterine sparing surgery, that is the sacrohysteropexy with sutures, and another one is colpoclasis. So I will counsel about all the options with pros and cons. Regarding vaginal hysterectomy, it is a definitive and major operation. Good thing is that it is the definitive operation and chance of recurrence is less. It is a major operation. Regarding procedure, it will be done under the general anesthesia or spinal anesthesia. Patient needs to be stayed for at least 2 to 3 days. And good thing is that
Go ahead.
sorry, ma'am.
Go ahead. Go ahead. Go ahead.
Yeah. Yeah. Okay. So good thing is that chance of recurrence is less, but there are some as it is major surgery. So there are some complications like anesthetic complications and surgical complications. Sometimes chance of increased pain, bleeding, infection, injury to the surrounding organs like bladder, urethra, bowel, and and after surgery, a patient can experience voiding difficulty, stress urinary incontinence, and dyspareunia if she is sexually active. And there is chance of recurrence, that is 1 to 10% chance is recurrence, and there may be also chance of wall prolapse. But along with that, I can reassure the patient that is it will be the complication will be less if it is done by the expert. Then patient will be counseled about the follow-up. Yeah. And regarding uterine sparing surgery, that is
Done,
his
done, done, done.
sacrohysteropexy with, yeah.
Just stop it
Okay,
now,
madam.
Arifa, Dr. Arifa. Okay, you have almost take 13 to 14 minutes.
Oh my God, ma'am. So
Your
I'm
history and first question by the end, your first question took 6 minutes.
yeah,
Okay.
history examination in.
Yeah, 6 minutes, and after that, so much of detail, detail, detail. You just you just need to be very to the point when it comes to structure discussion. If you are bringing so much knowledge into structure discussion, why the CT MRI in examination?
And sometimes prolapse can be associated with some mass or. I
Less like
said that
again,
if.
the abdominal examination is the key per abdominal examination, and then you said na bimanual examination.
Yes, ma'am, I forgot, and then after bimanual examination, I said about the parabdominal. Yes, ma'am. Previously, I forgotten to tell about the parabdominal.
Yes, 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 yes. So don't get confused. Be strict to what you wanted to say, okay? So that is totally irrelevant. You started on a very positive note, but then you went into so much of detail, you couldn't able to control your information giving or now knowledge.
Yes.
Okay. So my so there are many plenty good points in your task. There are many good points in your task, but you need to be concise, precise, justify why you want to do all those investigation, why you want to ask that particular history. You were most of the point time you were justifying why you want all these things. Okay, so that one point is very good about your answer key. Okay, uh, but you need to be concise, you cannot be so elaborative, you need to be
Yes, ma'am. That's
concise.
why. Yes.
Okay, so my answer key is my first question: what specific information you would like to ask? History, examination, and investigation. Here, actually, no details has been given, so it's just a random question. So, case of S bar is a case of genital prolapse. I would like to introduce myself. You mentioned very nicely. Take a brief history of symptoms, onset, duration, progression, whether she has tried any treatment, especially physiotherapy, any symptoms she had associated, that is bowel, bladder, especially SUI, constipation. You mentioned about digitation of the to remove the fecus. Contributory factor or risk factor, which includes asthma or comorbid condition like asthma, chronic cough, that is yeah, means this CO means what it is, corpulmonal. Okay, weight, occupation, obesity, difficult labor, mode of delivery, birth weight, as all these needs correction. How it is affecting her quality of life. Sexual history is also very important. You can ask sexual history in quality of life, whether it is affecting her quality of life, whether it is affecting her sexual history. Then menstrual history, postmenopausal, or issue on any hormone replacement therapy, uh, as lack of estrogen and associated atrophy aggravate symptoms. Smear if she goes for surgery. Okay, so we need to know the smear in this case. what examination you will undertake in the degree of prolapse. Okay. Medical sorry, this is my second slide. So medical and surgical comorbidities, if at all we are planning for a surgery, so we need to be aware about her medical and surgical comorbidity, as we need fitness for the surgery. Smoking, as it interferes with the healing of the tissue, and chronic cough is a leading cause for prolapse. Her drinking habits, as it aggravates urinary symptoms. Here I would like to offer her examination in the presence of saffron, local examination, per speculum per vaginal examination, and uh, pop q examination. So these are all my examination. Local examination basically involves to see whether there are any excoriation, whether there are any ulceration, surrounding tissue condition. Pop q examination to assess and quantify the prolapse. Investigation includes her bladder diary, if there are any associated symptoms, urine routine, and post-voidal residual urine. If need arises, then only ultrasonography and urodynamics testing in this case will be only then and then when the SUI will be associated with cystocele. Whether there needs to be SUI needs corrective surgery, or we can be managed. So overt SUI we need to rule out in this case. So these are the
Hello, ma'am. I'm
investigations.
not hearing you.
Are able others are able to hear me? Others are able to hear me?
Hello.
Hello?
Yes, ma'am. You're audible.
Yeah, I'm audible. Okay. Arifa, just check your internet. Okay. Now, what examination will you undertake to determine the degree of prolapse? Explain in detail. So that is my question here. Very nicely you had explained me. A POPQ, that is approved by International Continence Society. This examination is needed here. Advantage of this
Hello.
examination is, hello.
I'm not hearing, ma'am.
Uh, am I audible to everyone?
Yes,
Yes
ma'am.
or no? Yeah.
Yes.
What about you, Arifa? You just log in and log out. Log out and log in again. Re-log in. Just tell her someone to means log out and log in. Okay, she got disconnected. So the advantage is standardized technique avoids subjective errors. And inter-examiner reliability, reproducibility to assess prolapse at multiple vaginal sites for site-specific repair and for the success of the surgery. So more important thing is site-specific repair, success of the surgery, and it helps in follow-up also. Very nicely mentioned, Hyman is the reference point. Plane of Hyman represents 0. Any point above will be negative, any point below or distal will be positive. Minimize patient variation in management for site-specific repair. Whether procedure, now you have to introduce to the patient, you have to ensure that the patient's consent will be there, dignity will be maintained, bladder will be empty, stick will be taken with 1 centimeter mark. Okay. In a dorsal lithotomy position, it needs to be done in the presence of saffron. Ask patient to come for Valsalva manure. Then there will be a grid which contains 9 points. Okay. Anterior grid and posterior grid, AA, AB, and AP. Okay. Anterior wall, AA proximal point on the anterior wall, and BA is the most distal point on the anterior wall. In normally AA and BA are equal. Cervix will be the vaginal curve and D will be the pouch of Douglas. In hysterectomy cases, C will be curve in the curve of the vaginal curve. Okay. Posterior wall involves AP and BP. AP will be the most proximal point and BP will be the most distal point. Normally they are equal. GH is midline, from the midline of the hymen to the from the middle of the external urethral meatus up to the posterior fourchette. PB is perineal body, posterior margin of the genital hiatus to the mid point of anal opening, and TVL is the greatest length of vagina after reducing it. Okay, once you reduce it. Now stage 0, stage 1, stage 2, stage 3, and stage 4. 0 is no prolapse. Stage 1 is the most distal portion of the prolapse is more than 1 centimeter above the hymen. Stage 2 is most distal portion of prolapse is less than 1 centimeter or proximal to or distal to the planes of hymen. So it is less than 1 centimeter from hymen, above or below. Stage 3 is more than 1 centimeter below the hymen, but not farther than 2 centimeter. And stage 4 is complete vaginal prolapse, where here in stage 3 farther than 2 centimeter less than TVL. It should be less than 2 centimeter less than TVL. In stage 4 it is complete prolapse. That means it is equivalent to the TVL. So 0, more than 1, less than 1, above and below, more than 1, below, up to less than 2 centimeter of the total vaginal length, and it is equivalent to total vaginal length. Justify investigation. I couldn't able to ask this question to you, Arifa, because you had most of the points answered. Now coming to the management and more complication from these three for this lady. So the management starts always with the conservative treatment. The conservative treatment will be lifestyle modalities. If she is having any urinary symptoms, bladder diary, bladder training, Kegels or pelvic floor muscle exercises, which needs to be done under supervision of physiotherapist. For that, she will be referring to that. If the patient is obese, if there are any comorbid condition that needs to be addressed, if the patient is having smoking positive, we need to offer a smoking cessation services. So all those comes under conservative management. Depending upon the risk assessment and type of prolapse, we discussed about the options, that is a non-surgical option and surgical option. Surgical option includes vaginal hysterectomy along with site-specific repair, that will be anterior and posterior posterior perineuraphy plus minus sacrocolpopexy. If it is advanced prolapse, then sacrocolpopexy will be considered in this case to prevent risk of recurrence in future. Pessary, the pros of pessary, it's a non-surgical method, very good option when you need to buy a time for certain procedure, recommended in high, means where the medical fitness, surgical fitness will be of an concern. In those cases we will consider pessary as an alternative option. Cons with this will be retained pessary, sometimes it may cause infection, excoriation, and forgotten pessary. So these are the complications associated with pessary. You need to keep on changing pessary. You need to follow up for pessary change in pessary clinic. Vaginal hysterectomy, yes, it's an option along with site-specific repair plus minus sacrocolpopexy. Alternatives will be, as rightly mentioned by her, colpocliasis if it is morbidly uh, morbidly unfit patient, and where sexual desire of the patient is not an issue. In those cases only we can consider colpocliasis. Okay, pros and cons of the surgery will be get relieved, but the problems or the complication associated will be risk of anesthesia, risk of surgery, bleeding, injury to the bladder, bowel, new onset urinary symptoms, dyspareunia, leg pain, and recurrence of the prolapse. So these are the complications associated with this. Now coming to the domain-wise scoring, parity with details of the pregnancies and birth, including birth weight, past medical and surgical history, that is diabetic treatment, any systemic illness that causes prolapse, especially abdominal mass, occupation, chronic obstructive airway diseases, weight and BMI, ascertain the extent of symptoms and how these affect the quality of life, any associated urinary symptoms, these into dissect this into those of incontinence secondary to prolapse or it's a primary case. Communication in patient and family, in these cases in structure discussion, although they had mentioned so many things, it is basically introduce, take a consent for the procedure, dignity of the patient, dignity of the respect of the patient while examining is important, and discussing all the options with the patient including its pros and cons. So this is basically communication with patient and families. Colleague, refer to specialist, urogyne, continence nurse specialist, physiotherapist, GP in loop. Applied clinical knowledge, knowledge of the surgical complication of surgical management options of urogynecological disorder and pelvic organ prolapse. The new onset symptoms like acute voiding disorder, overactive bladder, and stress urinary incontinence. Ability to critically appraise the literature and evidence relation to the walled prolapse. And familiarity of NICE and RCOG, NICE guideline on urinary incontinence and RCOG guideline on walled prolapse. Patient safety here, basically patient safety is being safe throughout. Consent of the patient whenever POPQ has been offered to use the important consenting, maintaining dignity, presence of saffron is very important. If patient goes for surgery, then it is WHO safety checklist is very important. Safe prescriptions, safe options, including lifestyle modality, and surgical option. Pros and cons of all options is patient safety. Discussing with the patient is patient safety and understanding whether there is any contraindications to the procedure what you are going to offer. Drugs and common medical comorbidities if the patient is having, that also we need to consider in this case. Okay, so that is all included in patient safety. Anybody is having any question?
Ma'am, that means I have taken too much time on discussing all the procedure. No? Just need to mention about just name of the management. Like
Yes, actually you just to mention what you are going to manage, how you are going to manage, and then the pros and cons. If they
yes,
ask, if they're having
two
any
details.
information, they will definitely ask, so how you are going to perform? If that will be a question, then you are not having any time.
Yes. Mhm.
So that's the reason we stick to the format. Very on a very positive note, you have started. The only thing you have to concise your answer.
Yes, ma'am. Yes.
A very nice attempt. Thank you.
Thank you, ma'am.